Our next speaker is Wendy Conlon. Wendy is a genetic counselor. She works with the pancreas team. She received her undergraduate degree from the University of Vermont and a Master's of Science from the University of Arizona. And she tells us how to do this. She's really, really important part of the team. And she's going to be speaking on why should I see a genetic counselor.
Thank you, everybody. So I'm privileged to work with patients and families who are impacted by cancer, whether you have a strong family history of cancer and you're worried about your own risk, or you yourself have been diagnosed with cancer. And so I really like this cute picture of a family because it helps illustrate a really basic concept that a lot of speakers have been talking about. We get half of our DNA from our mom and half of our DNA from our dad. And genetics are the units of DNA, our genes are the units of DNA. They're the instructions that tell our cells what to do and what to become. Whether it's a heart cell or a pancreas cell, all of our cells have the same instructions that were present at the time that we were conceived, but we're really complex. Genes are turned on and off so that we have different tissues in our bodies that do different jobs. And so part of this complexity I like to illustrate with these puzzle pieces because all of these things fit together to give us clues as to what our lifetime risk is for many diseases. Our lifestyle, our behaviors, our environment, and our genes that we get from our parents work together, and family history is a tool that a genetic counselor uses to try to figure out what your risks are for certain diseases. And I work in the oncology arena, but it's true for many other common diseases, whether it's diabetes or heart disease. So we work with you to pull together your family history and your personal history to provide a risk assessment in addition to the genetic testing. Both components are really important. So why see a genetic counselor? We give you a personalized risk assessment based upon your personal and family history. We talk about the genetic tests that might be right for your situation. And I really love Dr. Donohue's cartoon that he had about the snow falling and this person looking in the window about the genetic testing options with the price tags, because I do talk to you about that. We talk about, is your insurance going to cover the cost of testing? And if it doesn't, what's your out-of-pocket expense? And what are your options for genetic testing? And what can it tell you? And what can't it tell you? We order your testing, we provide you with your results, and we provide you with a personalized management plan, whether you test positive or negative, because family history can change how we manage you and provide you with surveillance or risk prevention options. And then we're here for support. We're here to answer questions about genetics, which is changing rapidly, and we're here to provide education. So we want to be your partners in this process because we know it's complicated. The things that we look for in family histories that suggest an inherited risk for cancer: early age at diagnosis for certain cancers. This doesn't seem to be true for pancreatic cancer. So regardless of your age, kind of going back to what people said, if you're diagnosed with pancreatic adenocarcinoma, we really strongly urge you to get genetic testing, because it doesn't seem to matter if you're diagnosed at age 85 or age 25. Your risk to carry a genetic mutation seems to be about the same. The other things we look for in family histories are clusterings of certain types of cancers or individuals who've had multiple primary cancers in different organ systems, people who've had bilateral cancers, whether it's bilateral breast cancer or bilateral kidney cancer, people who have a common cancer but an unusual pathology like a triple negative breast cancer that raises our suspicion that there's an inherited predisposition. So all of those pieces of your family history help us figure out what the likelihood is that you might carry a gene mutation. And this is another cute picture of a family history. We've got a gentleman here who is in purple, and he was diagnosed with pancreatic cancer, and everybody else in his family has not had cancer. And we'd like to use pancreatic adenocarcinoma kind of as a sentinel for offering genetic testing and trying to figure out if you and your family have an inherited predisposition, because we would do things differently for your family members who also carry that same mutation if it's identified, and that can help prevent other cancers that might be more likely to occur in people because of their gender. So like, for example, a gentleman with pancreatic cancer, if he has a mutation, let's say in a gene like BRCA2, which is more commonly thought of as a breast and ovarian cancer gene, if we identify his sister and his mother who are still currently unaffected with cancer, we can work to prevent those ladies from getting the associated cancers with that gene and increase surveillance or offer them chemoprevention options, surgical options, things like that. So, family history is important. And then one of the things that I wanted to talk to you about is the genetics of cancer, which kind of goes back to the things that people have already been talking about. So everybody with cancer in their tumor, there are multiple mutations that have occurred that are allowing that cell to grow out of control. But people who have inherited mutations have inherited a non-working copy of a really important gene from one of their parents, but from their other parent, they have a working copy of that same gene. And that's not sufficient for people to get cancer, but it puts them in a higher risk group because our bodies make mistakes. So if we happen to lose that other working copy of that same gene from our other parent in one cell, that's how cancer can occur, because these genes are important for repairing DNA damage and controlling how our cells grow and divide, and it can lead to more mutations, and then a cancer can occur. And this goes back to my puzzle pieces. The chance to develop pancreatic cancer is based upon your family alone. And we do similar things for people who have strong family histories of breast cancer or colon cancer. So if you have two close relatives who have had pancreatic cancer, even if we can't identify a single gene or a single cause for that cancer, we change our recommendations for your unaffected relatives to have surveillance. So we look more closely at you because we don't know, going back to the puzzle pieces, is it genes that we haven't been able to identify or that we don't know about yet, or is it shared lifestyle, behaviors, environment, or some combination of those things? And one of the things that has really improved my job is a political issue. So genes used to be patented and owned by corporations in the United States, and the Supreme Court heard a case in the middle of 2013, and they decided that, and I thought this was a very good decision, that genes are not patentable because they are products of nature. And the analogy I like to use is, it would be analogous to me being able to patent coal in my backyard and prevent people from mining it in West Virginia, but that's what was happening in the US. So I've been a genetic counselor for a long time. It's been my entire career, and it was very hard to get genetic testing covered by insurance companies prior to this decision because the cost was so high. So for genes that I'm sure all of you have heard about, BRCA1 and BRCA2, it cost $5,200 to do those two genes, and we had very strict criteria about who could get that test based upon personal and family history. So when the patents went away, it took some time, but there's more competition in the marketplace. People have developed cheaper, faster, better tests, and it's been a game changer for me in my career and for my patients. There are lots of genes that we know increase the risk for pancreatic cancer, and it's not that there's one gene that causes one type of cancer. These genes increase the risk for several different types of cancers, but this is kind of a list of common genes that we know, or if you inherit a non-working copy, you have an increased risk for certain types of cancers. So we can test for these. We can test for many other genes that we know are associated with pancreatic cancer risk. And it's important because a lot of these genes don't just increase the risk for pancreatic cancer, they increase the risk for other common cancers. And one of the things that I hear a lot from people is, well, it's just a simple blood test, so let's just do this. It's really easy to collect a specimen, but not so easy to perform the genetic testing and then make sense of the results, because we have 20,000 genes, and the list of genes that I showed you are fairly well studied, but there are newer genes that we haven't tested lots of people for. We have databases of normal genetic variation, but we have racial biases in those databases. So if we look at the cataloging of normal human genetic variation, those databases that we have are heavily skewed towards Northern European Caucasians. So we don't know what the normal genetic variation is in people of Asian or African ancestry, for example. And so that's a problem, and that's why we need to get more people tested to make more sense out of the genetic testing information. So the professional group, the American College of Medical Genetics, has reporting standards, and not all laboratories use these reporting standards, which is unfortunate, but reputable labs do, and it can be complicated, so you really want to make sure that the person who is ordering your testing and reading that result understands the meaning of the classifications. So there are 5 classifications, and so if you order a genetic test, you get results back, and if they see a genetic change, they pop it into one of these 5 categories. And so the 2 top categories are pathogenic variant, where we're absolutely certain that this change will knock out the function of a gene and you have a diagnosis of the condition associated with that gene. The second category is variant, likely pathogenic. So the abundance of evidence that we have is that it probably knocks out the function of a gene, but we're leaving a little bit of wiggle room that maybe we're wrong. There's a third category which creates a lot of confusion. It's called variant of unknown or uncertain significance. So this is really just a placeholder for the laboratory. They saw a change in your DNA. It doesn't follow the rules where we understand would knock out the function of a gene, but it's different. And this gets back to the racial biases that we have in our catalogs of normal genetic variation. Most of these are representative of the differences between all of us because we're not clones of each other. But sometimes people misinterpret these as being significant when they're not. And then there are lots of differences between us because, again, we're not clones, so we see lots of benign variants or likely benign variants in our DNA because there are millions of genetic differences between all of us here in this room today. And so the role of a genetic counselor is to help you understand your genetic test results and make a plan going forward for yourself and your family members. The way that we handle these results is listed here. So a positive result, we increase your surveillance. We manage you based upon consensus guidelines or scientific literature for somebody who has a mutation in that particular gene that knocks out its function. Variants of uncertain significance are not to be used for medical management because we know that the vast majority of them are benign and representative of normal human variation. It is possible that over time, a laboratory or the general scientific community will gather enough information about a particular variant of uncertain significance and reclassify it to pathogenic. I can tell you that maybe once a year that happens for a patient of mine who was tested, 5 years prior or 2 years prior, or even in one case a month prior. But it doesn't happen very often because most of these, greater than 90%, are completely benign. Most of the time I get contacted by laboratories, and I would say this happens on a weekly basis, where they're reclassifying a VUS to benign. But this is part of the uncertainty and the difficulty in handling genetic testing and making meaning out of the testing that we do. And then how do we manage a negative result? There's actually 2 categories of a negative result. There's a true negative result. So if you're an individual who has a parent who has a BRCA2 mutation, and we have documentation of that, and we test you and you don't have it, that is a true negative result, and that takes you off the hook for an increased risk for cancer. And your risk goes back to the general population risk because we have, in fact, clearly proven and tied up with a bow that the cancer in your family is due to this particular alteration and you have not inherited that mutation. And this kind of goes back to the importance of testing people who are affected with cancer first in a family, if at all possible, rather than starting with unaffected individuals, because we want to start with the person who's showing signs or symptoms of the thing that we think might be genetic, because the vast majority of people who have cancer do not have inherited mutations in that list of genes that I showed you. The other thing that happens is we do genetic testing on people who are healthy and unaffected or have cancer, and we don't find a mutation. And that's a negative result, and that's very reassuring, but that still leaves us some questions. It could be that this person or this family has a mutation in a gene that we haven't identified yet. It's also possible that this person or family has a mutation in a gene that we actually tested them for, but we just can't see it with the way that we're currently doing the testing. So it leaves us with a little reservation about maybe we've missed something or maybe there's something else. And so we fall back on managing based upon family history, which was that chart that I showed you. If you have family members who have had pancreatic cancer, 2 close relatives, we would recommend increased surveillance for you. If you have multiple family members with breast cancer, we would recommend increased surveillance for you. If you have multiple family members with colorectal cancer, depending on the degree of relationship and age, we would recommend that you start a colonoscopy earlier and do it more frequently. And that's just treating everybody with an abundance of caution, because there still are unanswered questions about why some families look like they have more cancer than we would expect by chance. And so there are benefits and limits of genetic testing. You get a personalized risk assessment. We can help provide you with precision medicine, because one size doesn't fit all. We all know that not everybody in this room has the same risks for diseases, whether it's heart disease or cancer. It's important information for family members. It can reduce stress and anxiety to know a cause or a reason for why cancer has occurred in a patient or a family. A negative result for a no mutation, like I said, is a true negative result, and that's a really nice thing to be able to give individuals. And there are limitations. Like I said, genetic testing is not perfect. We miss things. It can be inconclusive or ambiguous, and that can be stressful for patients. And then there's a thing called survivor's guilt. So in some families, if you test negative for a no mutation, some people feel guilty about that, even though none of us have any control over the genes that we have inherited from our parents. But you might think, well, I'm more capable of handling this than my sibling, who maybe has other problems that create difficulties for them. And constrained family relationships, because some people don't want to know about genetic risks for diseases. They want to take life as it comes, and so there can be some disagreement within families about who should be tested and whether or not testing should occur. So I want to thank you all. I really enjoy my job as a genetic counselor, and I love it, and I love working with patients and families to make sense out of all of this very technical information. So thank you for allowing me to speak to you today. I want to thank the Pancreas IPU and Dr. Donahue and Dr. Hines and all of the staff that I work with there. And I want to thank my physician supervisors, so Dr. Mary Seal and Dr. Patricia Gans, who started the cancer genetics program here many decades ago. And I work with another genetic counselor, Rachel Shapira, who's fantastic. And I want to thank the Boyer Oncology staff for supporting us and helping us see patients when they come to see us. So thank you. Hi.
I have another question. So sorry.
Don't apologize.
The Garden 360 we were talking about, could that be used for genetic testing for a patient? Because we know that they're having signs and symptoms of pancreatic cancer, and that would be something, or is it only testing the tumor circulating cells?
So the Garden 360, my understanding is just testing DNA shed by tumors.
Right.
But I think that testing is still in its infancy, and that's not testing that I order on patients ever. So when I order testing, I want to take a normal piece of tissue from you to test the DNA that you had on board as a child to see if you inherited a non-working gene from either your mom or your dad that explains an increased risk for cancer, because we're trying to risk stratify you. So your question is kind of out of my area of expertise, and I think that that's an ongoing area of research, and I don't know that we have really a good handle on how to use that information, because it's also possible that we could find circulating DNA that's not representative of your germline DNA. And if we found it, how would we find your tumor? Because we need to have billions of cells to be able to detect a tumor based upon imaging. So I think there's still some limitations in the use of that test.
Okay, thank you.
Hi.
Hi.
I was diagnosed with pancreatic cancer in March of 2017, and they did some of the genetic testing on me, and everything came back insignificant.
Do
Okay.
you know if they did the genetic testing on your tumor or on a blood sample?
On the tumor.
Okay, so I'm talking about genetic testing on a blood sample to see if you have inherited a mutation from either your mom or dad that explains your diagnosis. And there is some differences between testing a tumor sample versus testing normal DNA from a blood or saliva sample or skin or non-tumor sample. Your tumor tissue is fixed in formalin and then placed in wax, and it is possible, and it does happen actually, your DNA gets kind of chopped up in that process. So while the testing of your tumor can be important and can find changes in your tumor that would drive therapy and might also pick up inherited changes, it doesn't always, and it doesn't replace the germline genetic testing of blood or saliva to look for inherited mutations because of the damage that occurs to your DNA in the tumor as part of the fixative process. So we do know that sometimes the tumor testing that you're describing misses inherited mutations, which is why we have to do this separate test on normal tissue to see if you have an inherited mutation that explains your diagnosis. So they're two totally different tests, and there's limitations to both.
Okay, I didn't quite finish. And they did the blood test to look
Okay.
for that kind of.
Awesome.
Okay, I just want to say that since it all came back insignificant, I told my brother, and I have a sister, I mean, everything looks good. You don't have to go get tested. My sister came down with pancreatic cancer 2 years later.
Oh,
Okay?
sorry.
So this is one of those things where I know this is all new and, we need more data so you can look at this stuff. Just, what do you think about trying to get everybody to give DNA?
Well, so what year was your testing performed, your blood test?
When was the blood test done? The same time. It was done in March of 2017.
Okay, so it depends on who did that test and what center you went to, because there's not one test for inherited mutations, and there are multiple laboratories that offer it, and they offer different numbers of genes, and they have different abilities to detect mutations. So it's a great idea for either you or your sister to take your genetic test result and go see a genetic counselor and see if they missed anything. So right now, when I see a patient with pancreatic cancer, I give them two options. One option is to do about a 40 or 50 gene panel that looks at medically actionable genes. So these are genes that we know are associated with an increased risk for different cancer types, and we have medical management guidelines for those genes. Not all centers even do that number of genes. And then there's a second option for people who have a good ability to deal with uncertainty or ambiguity, because there are many, many other genes, because genes don't work in a vacuum. They work in complex pathways with other protein products of genes to do a job. And so back to my favorite example of BRCA2, that works in a pathway called the Fanconi anemia pathway, and there are 50 to 100 genes that work in that pathway, and we can test for them. We have some data that some of those genes are associated with pancreatic cancer, but we're not sure. And so I don't know what level of testing you had, what number of genes you had, or if that testing was done in a medical grade laboratory that I can be confident that they would be able to detect mutations, because some laboratories out there only do partial analysis of some genes and may miss something. So it's a really good idea, since there are two of you now in your family, to revisit what testing was done on you and maybe think about having an updated test.